Now, being admitted to the profession of medicine, I solemnly pledge to consecrate my life to the service of humanity.
But it's much softer.
Yeah.
That's good. But she seems to be in as much coma, and again, not feeling any pain and not reacting in that way. The eyes are maybe a little more sluggish, not quite as reactive as yesterday.
I will give respect and gratitude to my deserving teachers.
There was a antagonistic relationship between many of the faculty and students, and I remember in particular one faculty member in biochemistry would rail at us and say, if you don't know this point, you're going to become a killer when you go across the street and work in the hospital.
I will practice medicine with conscience and dignity. The health and life of my patients will be my first consideration. I will hold in confidence all that a patient confides in me. I will maintain the honor and noble traditions of the medical profession. My colleagues will be as my brothers and sisters. I will not permit
For thousands of years, physicians have been learning medicine at the patient's bedside. Learning medicine is a tradition of hallway discussions, an update on new treatments, an art and a science passed on to succeeding generations of healers. The patient is the key to the education of a physician. Learning medicine is learning about people, how they work, how they live, what makes them die. The patient is also the ultimate judge of the physician's abilities, and all too often in our time, patients are expressing dissatisfaction with their medical care. They complain that they're viewed as diseases, as cases. They say that their physicians don't take time to listen or explain. They have trouble finding their way through the medical maze. They sue physicians for millions of dollars. Medical students and educators are also frustrated. They work in a system where learning is fragmented and where students' lives are significantly disrupted, a system that fosters episodic rather than continuous care. They work in an environment that is increasingly separating the rich from the poor. For too many physicians, medical school is a time they would rather forget.
It works for some people who have a photographic memory, who are highly motivated to absorb every minute little fact. But for the majority of us who don't know what it all means and where it all came from, all those little facts just zip by, and they don't stick.
My quickest way of summarizing what medical school was like for me was to quote some anonymous cynic who observed many years ago that medical school looks like it was designed to put students in jail for 4 years in an effort to teach them how to be free.
This is a story about a different way of learning medicine, an approach to learning that offers a promise of more effective communication and understanding, the promise of better care. This is not just a story about doctors. It's a story for all learners and for all teachers.
These promises on it feeling and falling on.
About my aching head. Hip bone connected to the neck bone. I went to my doctor and this is what he said. Them bones, dry bones. He said my cervical was low and my occiput was high. Yeah. Doctor, please, doctor, doesn't mean I'm gonna die. Backbone connected to the hip bone. Please, doctor, tell me if you can. Tell me in some words that I can understand. Yeah. Doctor, listen, I said, give me some advice.
Each fall, I watch the best and the brightest. I watch them turn into depressed, bored, concerned people that aren't having fun. At the same time, I know that we're telling them all of the things that they need to know to be good doctors. And I know that they're working as hard as they know how to learn all of the things that they must know to be good doctors. And yet, when my colleagues and I see them 2 years later in the clinical setting, our experience is that they don't remember anything of what we told them.
A central issue is that in most medical schools, most students spend most of their first 2 years sitting passively, being told things without knowing why they need to hear those things, and without having a chance to actively participate in searching out the information they're being given. As one of my colleagues puts it very well, they are constantly being given wonderful answers to questions they never asked.
Are we facing yet another crisis in education? If our medical students are bored, depressed, less than enthusiastic, what does that portend for our well-being? Each year in the United States, about 17,000 students are accepted into what most experts feel is one of the most rigorous postgraduate training programs of any profession. Medical school lasts 4 years. The first 2 years are traditionally devoted to the study of the basic sciences: anatomy, biochemistry, microbiology, physiology. A few of the sciences that provide an understanding of how the body works, the essential foundation for the study of medicine. The basic sciences are traditionally taught in lecture halls and laboratories, taught mostly by non-physicians, by PhD scientists. It is these 2 basic science years that have been most criticized by medical educators and by medical students. In Hamilton, Ontario, Canada, McMaster University School of Medicine has provided international leadership through its innovative approach to medical education. Dr. Victor Neufeld is a member of a special panel of educators who have recently looked at the problems and suggested solutions for training physicians for the 21st century.
The main problem I see with basic science education is that it's not connected, integrated. It's fragmented. It comes in parcels that are called anatomy, physiology, biochemistry, histology, lots of ologies, not connected to each other, not connected to patients that the students will look after in a very short time. I think another problem is relevance. We don't help the students realize why they're learning this information, how they can use it.
The fragmentation of learning that we see in the first 2 years of medical school is continued into the second 2 or clinical years of medical school, because we don't prepare our students for the broader needs of patient care, the economic needs, the needs to win the patient's way through the maze of a social agency. All of those things are the broader humanistic needs, and we are too narrow in our preparation of students. Secondly, we don't prepare our students to give each other enough support in the kind of very stressful environment that patient care can mean. We need to do more of that.
The problems with medical education are the same problems that face learners and teachers in almost every educational experience, from kindergarten to graduate school. Traditional education encourages competition rather than cooperation. It is teacher-centered rather than student-centered. It is mired in a groove of passive learning, spoon-feeding information to students, lecturing to them, rather than creatively encouraging them to learn for themselves.
I don't think there are villains. I see conscientious students. I see conscientious faculty. So I have to blame the system. And I think the system is at fault because fundamentally of what we know about cognitive structure, that if you learn something in one context and have to recall it in a totally different context, the probability of recalling it is very low.
The majority of medical students spend half of their formal medical educations in classrooms and laboratories, trying to learn volumes of detailed information, trying to separate the relevant from the esoteric. They've been stuck in an educational system that has divorced the student from the teacher and the classroom from the community. The learning of our future doctors, and by extension, the care of our bodies, has been fragmented. It seems strangely ironic that medical students' most profound clinical involvement, their most sustained personal contact during their first 2 years of training, will be with a cadaver.
Talk about the bones. Talk about the bones. Talk about the bones.
What we were talking about is the importance of animal diseases and understanding human diseases. And in the Southwest, with the bright sunshine, we get a lot of skin cancer. We have an animal model here in this cow. And she developed cancer of the eye. And it's what's called a squamous epithelioma. I think it's an important model that could be used in the study of human cancer. It's very, very similar to it. You've probably seen patients with skin cancer in this area. What do you think it's largely due to?
Well, we were talking about the pigmentation being an important aspect of protecting against ultraviolet rays.
All over the state of New Mexico, a unique experiment in medical education is underway. In place of lecture halls, rural communities have become classrooms, and country doctors have joined a medical school faculty. As a result, first-year medical students like Regina Valencia have acquired new role models and new perspectives about medicine. The primary care curriculum at the University of New Mexico School of Medicine has combined the theory and the practice of medicine and brought it into the community.
Fair-skinned people at high altitude exposed to a lot of sunshine, such as we have here, are very prone to get it, which is a very benign sort of cancer. But this one we have in the cow is exactly the same type of tumor as we see in the cervix in human, in the esophagus, in the floor of the mouth.
Any squamous cell.
Any squamous cell area, exactly.
Dr. Alan Thal is not a veterinarian, although he does know as much about Herefords as humans. Alan Thal is a former professor of surgery who decided he'd rather be a country doctor. He's one of many physicians from small New Mexico towns who have volunteered to become tutors in the primary care curriculum, role models for first-year medical students. Regina Valencia is spending 4 months at the end of her first year of medical school learning with Dr. Thal, becoming his apprentice, learning around real problems in a small town surgical practice. Instead of learning on a cadaver, Regina is getting a living lesson in anatomy. The primary care curriculum is an experiment in active learning.
Was a good Samaritan last night and tried to take a gun away from a man who was shooting somebody, and as a result he got shot. And we want to take a look there. We just saw the x-rays with Dr. Whiteman, and what can we say about the x-rays?
Well, they didn't show any bone injury.
Yeah, that's very important, isn't it? And very important indeed. Now, the other thing that we need to know right away is has he had a tetanus shot? Is he in satisfactory state from tetanus, for tetanus immunization? And has he been having any, was he given any antibiotics?
A tetanus shot 2 weeks ago and was treated last night during the night at another hospital, received no antibiotics.
Very good. Now, what's the first thing you noticed? You describe the injury to me, would you? Okay. Just turn your head over this way, Miss Benavides, just over towards me. That's good.
You have a lot of swelling right here.
Yeah, it has a lot of
in
swelling.
The area of the wound. Is this painful? It's not painful? Okay.
No, he's just being
Feeling
very brave.
no pain.
You know, around here, being macho is very important. He wouldn't tell if it was painful, no matter how painful it was. Isn't that right, Bobby? I know Bobby very well. As a matter of fact, Bobby was shoeing my horses last week. And I've got to keep Bobby in good shape because he's a real expert farrier. And I'm dependent on him, he's dependent on me. Bobby was probably saying something uncomplimentary to the guy at the moment that he shot him. I know Bobby. These students have their enthusiasm stimulated by the fact that they get right in almost from day one and are exposed to patients, which is really the reason most of them go to medical school, because they want contact with patients. And that's one of the chief pleasures of clinical medicine, clinical surgery. So I, having worked with the other groups of students as well, detect an enormous difference between this program and the students in the regular program.
The bullet entered his mouth. It came in like this and came out through his cheek, completely missing any of the jaw and not damaging any of the teeth. We took x-rays in this position and he showed no breakage of jaw or teeth, although he did say that he had some loosening of his teeth.
You mean his mouth was open?
Yeah.
Is this a self-inflicted one?
No. He counted off 6 shots and the guy had a 9-shot gun. So apparently he was trying to get apprehend the guy. And
gonna bite the bullet.
He was yelling. When you think about change, the question then becomes, how can you change a traditional institution that's so set in its ways? So what we decided to do is see if we couldn't introduce a new kind of learning that would address these problems in a way that was more acceptable. So we started with the idea of a very small experiment, a small track of students testing a new idea in the middle of a more traditional setting here in New Mexico.
New Mexico was an ideal place to try an experiment in medical education. A large rural state with only one medical school, New Mexico had been struggling with the problem of providing physicians for its underserved rural areas. But to suggest that first-year medical students should leave a large urban medical center to study in a small community was a somewhat revolutionary idea. In the mid-1970s, a group of young faculty began to experiment with the strategy of taking first-year students out of lecture halls and into rural communities. They theorized that by introducing students to real patients and real problems, the students would have a better understanding of how the basic sciences are applied. They also hoped this early exposure to community-based medicine would create a more balanced education, that it might even have a positive influence on future practice patterns. The students were incredibly enthusiastic about this active learning experience, and in 1979, the W.K. Kellogg Foundation funded a proposal to run an experimental track alongside the traditional curriculum track at New Mexico. The Primary Care Curriculum, or PCC as it's called, was born.
Hello.
Well, hello, Ron. How are you?
Good. I made it.
Come on in.
But most of all, we wanted to design a curriculum that was exciting and fun for the students. And we know that when you're dealing with real patient problems, trying to solve problems, that's thrilling and it's exciting for all of us in the health field. In a traditional education, you don't see a real patient for the most part for 2 years. But in PCC, we decided we're going to give them real patient problems from the first day of medical school.
Hear that high-pitched tinkling? That's characteristic of intestinal obstruction.
I know.
And of course, she's distended.
What does it sound like?
Well,
we also realized that the traditional teaching hospital is not an environment that's conducive for students understanding about the community. And yet the community is where almost all illness originates and where almost all doctors will eventually practice. So we decided to make the community as important a learning experience as the hospital. So we have PCC students going into the community, working in a variety of clinic settings, having them go into schools and care for children, doing community projects, and really giving service to that community.
Mr. Mayor, I want to introduce you to our new medical student, Ron Battle. He's going to be with me.
Finally, we wanted to change the very passive way that students traditionally learn in our society. They take reams of notes, they memorize for examinations. In PCC, we wanted students to be very active learners. We put them in small interactive groups. We have them take responsibility for their own learning. And that's very important because there's not going to be a lecturer in the future telling them what book to read when a patient comes in with a problem.
By transferring the responsibility for learning from the teacher to the student, the PCC has all but eliminated the one thing we associate most with education, the lecture.
Please, doctor, tell me if you can. Tell me in some words that I can understand.
There's a sort of a feeling in the academic community that when Moses came down from the mountain, he was actually carrying another tablet that in addition to the 10 Commandments, he was actually carrying one that explained how we should teach. And of course, it said, the way one teaches is to lecture. That's why we know that we should lecture. And of course, across the country, what happens is that academics believe that learning occurs because they teach. Now, we know that's wrong, but that gets deeply imbued in our souls. We begin to think that because we're standing up in front of the class, students are learning. Students learn when their minds are actively engaged.
People are not cared for in lecture halls, so the PCC has moved the teaching and learning to where the patients are. The whole structure of PCC is problem-based learning, and here comes a problem.
Lifeguard 1, this is UNMH. Go ahead with your transmission.
MH, this is Lifeguard 1. We have unconscious child, possible meningitis. Blood pressure is 90/60. Pulse is 120. Respirations are 30. We have an IV started with D5W TKO. Over.
10-4, we'll be expecting you. WB 239 clear.
Are you his mother?
Yes, I'm his mother.
Can you tell me what happened?
Well, I don't know exactly. He had just a cold, some runny nose and some congestion, and I guess he had an ear, complained about his ears this morning, but he seemed fine. I wasn't that worried. I thought, you know, just a cold, that sort of thing. I had a doctor's appointment for him this morning, and or this afternoon. I had it set up for this afternoon, but he didn't seem that sick.
How long has he been unconscious?
Well, I don't even know exactly. I went shopping this morning, and he was being babysat by his brother, and when I got home, I just found him by the bed.
His mother gave him an adult aspirin tablet and a teaspoon of a over-the-counter cold remedy. He was able to sleep about 4 hours, but then awoke complaining again of ear pain. He was given another aspirin tablet and slept until morning. So two aspirins in a 5-year-old child, 2 adult aspirins.
Do we have any history of a fever?
There's no history that his temperature was taken, so we don't have any documented fever, and the mother didn't comment initially.
Well, if it was an infection, to make him unconscious, it would have to affect the central nervous system. It seems like it would have had to spread to the brain and the spinal cord, or at least the brain too, if that's what is causing him to be out cold. His brother could have tried to cure him with aspirin while his mom was down.
Yes, or just some kind of household poison. Does that come under toxicity?
Yeah.
He could have gotten hit in the head while his mom was out too.
Trauma.
Jenna, what'd you find on physical exam?
Well, he's got a little fever. He's got a temp of about 38. He's breathing kind of fast at about 30 a minute. And he's got a bruise under his eye that I found.
Check his ears?
Yeah, I think he's got a radiator. I'd like you to look at it.
What's your plan?
Well, we did a lumbar puncture already, and the spinal fluid's in the lab, and we should know pretty soon whether he has a meningitis or something like that. And now I think the first thing we need to do is get him down to X-ray to make sure he didn't fracture his skull or something because of that bruise under his eye.
All right.
What can cause unconsciousness in a 6-year-old child? Infection, trauma, poisoning? Jamie Opal's case is a typical problem, not only for third-year student Janet Mullins, but for students beginning their first week of medical school as well. Students in their first year are certainly not very medically sophisticated, but they can ask questions. They can suggest hypotheses. They can look up information, and that in turn stimulates 100 more questions. And that's how they learn. During the helicopter ride, Jamie had a difficult time keeping his eyes closed. He'd never been in a chopper before, and he wanted to see the sights. Jamie and his mom are simulated patients. They're actors, trained and paid to simulate an impressive array of ailments. This routine helicopter training session at the University of New Mexico Medical Center provided an opportunity for the PCC to simulate a medical problem. PCC students will interview and examine simulated patients. The students will then bring their problems back to the tutorial group for discussion. This small group setting brings 5 or 6 minds together to explore the relevant basic science and patient care learning issues.
Let's say in this child who's unconscious that has an earache, how are we going to tie his earache into his unconsciousness, or are they 2 separate problems? Is there, can we see some direct anatomy and some how it would spread from that model, or is it not good enough?
Some direct connection, but I'm not exactly sure what it is.
He seems to have an otitis on this side, and his right ear is normal. What about a spinal tap?
That was normal.
Okay, how about an aspirin level?
We could have a ear infection from bacteria with secondary aspirin toxicity.
All right.
And no meningitis.
And that is what Jamie Opal's problem was. A middle ear infection complicated by aspirin toxicity. But the learning doesn't stop with the diagnosis. Students continue to identify learning issues. The anatomy of the ear becomes a critical focus. Could an infection have spread from the middle ear to the brain? What would a skull fracture look like? What's the normal rate for a child to breathe? The case has stimulated multiple areas of learning, and the learning is fun. It's relevant. It's real. Tutorial groups learn how to interact. 5 or 6 different people with different styles all have to learn to work together. They have to learn to be helpers, to become more effective as teachers. Effective communication becomes essential. Tutors function as facilitators, helping to direct but not overpower the group. The tutor is usually a physician or a basic scientist, sometimes a team of both. It's a completely different role for most professors, and it requires changing some old habits.
The differences are profound. In fact, they're really opposite in their approach. The traditional approach is a one-way street. The teacher gives the information to the student. The tutorial approach is a sharing. They work together as a group. The important part is that the student learn to acquire the information rather than simply to receive the information. And it's sharing in that process, undergoing that process, that becomes exciting. It's dynamic, it's vivid, students are excited. I love it.
In dramatic contrast to the first 2 years of a traditional medical curriculum, where student time is spent in a highly structured network of lectures and laboratories without patients, PCC students spend their first 2 years learning around real patient problems in these small interactive groups. The tutorial groups meet about 3 half-days a week, leaving considerable time for electives and independent study. PCC students leave the medical center for 4 months in the spring of their first year, learning and applying their knowledge with a physician preceptor in a small New Mexico community. PCC and traditional track students